Yeah, Zoom all changed a little bit, Anna.
I know, hopefully this is recording to the computer, but we'll see. A podcast by respiratory leaders for respiratory leaders. This is RT Sidebar. Stay tuned.
All right. Miss Anna Hayes, it's so nice to see you as always in 2025. Super excited to get season 3 started off. This is RT Sidebar. I'm your friend, Matt Pavlichko. Season 3, 2025. We're starting with a little international flavor, Anna. We have our friends from the UK. I have my Liverpool on to represent. I feel very British today because I very, very proper. But it's super excited to have Ben and Phoebe on because, they don't have respiratory therapists in the UK, but they have respiratory patients and they have respiratory physio. So we're super excited to learn a little bit about the UK. And I'm super excited. So Ben and Phoebe, thank you so much for being on. We really appreciate it. Ben, I'm going to start with you. Tell us about being a respiratory physio in the UK and what does that mean?
So I think it's a fairly similar path. I mean, it's definitely for both me and Phoebe. It's not a
Mhm.
well advertised career. So we both went to university to be sports physiotherapists,
Hmm.
and then did a little bit at uni, realized it wasn't for us. And then over here, when you start as a physio, you do rotational jobs. So you move around
Hmm.
all the different areas as a physiotherapist. And we sort of, to start with, it's closer to what would be a physical therapist in America.
Yeah.
So we sort of work across musculoskeletal outpatients, neuro and stroke rehab, community therapy, med eld, and respiratory. And I know, particularly for myself, it was the one area that very much piqued my interest,
Okay.
particularly around the fact that you could make a almost immediate impact to somebody instead of where it's MSK outpatients. You give them some exercises, you send them home for 2 weeks, they come back, they haven't done the exercises, nothing's changed. Whereas respiratory, you're there half an hour, the sats have gone from 70 to 90, 96, 97. And it was that immediate impact that sort of enticed me in.
That is really cool. So you as when you went to university, you learned all the therapies. So you learned did you learn like physical, occupational, a little speech, a little bit, and then respiratory? You learn a little bit of everything?
So we have over here, the way it's structured, we have allied health professionals. So
Okay.
occupational therapy is separate, speech and language is separate, prosthetists, orthotics, all separate. And physiotherapy focuses more on the rehabilitation side. So more of the big motor movement, so
Okay.
mobility, um, transfers, that side of it. Well, the OTs focus on more like the fine motor, so washing, dressing,
Okay.
kitchen tasks. So we sort of focus on all areas, but all areas of medicine, but from a purely rehabilitation point of view, and very much a physical rehabilitation.
That's really interesting. So Anna, that's kind of like nursing here in the United States. You learn a little bit of everything and then you specialize once you're done. So Phoebe, tell us your story. Like how did you get into respiratory physio?
So I think similar to Ben, when I were still at school, I thought, oh, physio, that sounds like an interesting career.
Hmm.
Again, looking down the sports pathway, wanting to be a sports physio. But when I got to uni and I actually did the sports side of it, I thought, oh no, I don't think this is for me.
Okay.
And as soon as we started sort of doing placements, so the way it works at uni is you do like several placements in different areas. So you get to sort of see each area physio. So
Hmm.
like neurological, orthopedics, pediatrics, respiratory, MSK outpatients. And when I did my respiratory, I thought, actually, I think this is something that I might quite enjoy.
Okay.
So then when you qualify, you can sort of go down the route of if you work for the NHS, like Ben said, you work sort of around each area as a newly qualified physio. So then when I did the respiratory, that's when I thought I really enjoy this. I feel like it's an important role because you can, get
Hmm.
patients better straight away. Yeah, just really enjoyed it. And I think when you say to people, "Oh, I'm a physio," they assume you're an MSK physio rather than respiratory. Even family members think, "Oh, can you help me with my back? Can you help me with my knee?" But respiratory is obviously a separate area, which it's not very well known, I don't think, over here.
Well, I will tell you, in the United States, it's not well known either.
No.
When you think of therapy, you think MSK, you think physical therapy, think occupational, you don't think respiratory. It always is. It always seems like we're not a good marketer of our own profession, to be
No.
honest, because nobody really knows about us. But I had a physical therapy leader once tell me, I don't know why respiratory is not at the top of the list, because respiratory is taking care of patients that are going to die, and you fix them. So, it when you got into respiratory, is that what drives you? Like, tell us, like, what drives you to be excellent in respiratory therapy? Because I agree, I'm a respiratory therapist. I like breathing. I like lungs. That's what I like. But like what jazzes you up? What gets you excited? Ben, what do you think?
I think it's, for me personally, it's the sort of more complex, multi comorbidity
Mhm.
patients where you've sort of got everything else going on. And I think as physios over here, we're in a good position where we can look at things holistically and we can sort of almost be the go between the nurses, between the medics, between the OTs, and sort of almost act as that middleman and go, actually, they're extremely breathless. Why don't we try this medication to help settle it so
Mhm.
that we can then get the rehab side going and improve the quality of life going forward? Or the acutely unwell one, sort of like, right, well, leave the chest to us. We'll sort the secretions. We'll manage their oxygen demands, and then sort of free the doctors up or the nurses to manage other things that we aren't able to do.
That's interesting. Phoebe, do you have a story or a patient that really jumps out at you and say, this is why I do what I do?
I think, well, just going back to what you said before, I quite like the fast pace of
Yeah.
the respiratory, so things can change quickly. I like the medical side of it, like Ben said, we get more involved with the medications, which you wouldn't do on any other rotation, and just being involved in that MDT. But something that jumps out, probably I quite like working with the breathless patients like pulmonary fibrosis, and then working through COVID and flu, working with the MDT like palliative care to
Oh,
sort of help the symptom management so we can get them up and going again. So the patients that are too breathless, um, can work with them to help manage that breathlessness so we can get them moving again. So that's where our rehab side comes in, that we can get them up and walking. And again, where the vape therms come in, we can now use that to help mobilise these patients, which has helped the outcome for them. Whereas before, the high flow machines that we used, we couldn't mobilise patients on the high flow. So we had to sort of wait until they were on a set amount of oxygen to be able to take them off to then mobilise them. So it's been a lot better for the patient care, getting them back to sort of their normal quicker. So that's really helped us massively, being able to use that.
there is a big push in the United States to mobilize patients. So you're in the ICU, you're sedated on a ventilator, and you could be sedated comatose for 2 weeks. And a really pioneering physician over here, Dr. Wes Ely, says, hey, we saved your life, but you can't walk because you've been sedated for so long. Being able to mobilize patients, the palliative piece, is that the future? Like, where do you, like, how do I say this? Is that the future of respiratory care? Like, whether you're a physio or a therapist, is that where it belongs? It's making breathlessness go away. Because when we think about what our job is, we always said I save lives for a living. I put people on ventilators, I bring them back from death. But is that what we should be doing?
I think that's where our job's quite nice is because we get that side of it,
Hmm.
and then we also get the rehab following it up. I mean, it was absolutely hammered into both of us when we started. The best thing you can do for somebody's chest is get them out of bed, get them on the feet, get them walking. It's much better than some of the treatments you can do for somebody lying flat in bed. If you can get them on the feet, you're going to improve lung volumes and functional outcomes at the same time. So it's a sort of win-win.
I think that's where you guys being MSK and learning a little bit of everything actually is a huge benefit. So we in the United States look at lungs as respiratory therapists. We're a little bit narrow focused, but you're getting patients up. Do you walk patients that are on ventilators?
So we neither of us two are ICU based as
Okay.
speciality,
Okay.
but I know our ICU physios are looking into it. Um, at the minute, we'd look to mobilize people on NIV and we'd look to mobilize people on nasal high flow,
Hmm.
even if it is just sitting out of bed rather than hoisted, and then we'd look to actively transfer them. Just
Okay.
again, get that bit of functional movement in there as well.
So Phoebe, when you think about, you're going to add a new technology to help them move, like how do you change the thought process with this? Because a lot of times, it's easier if they're sedated and they're on their NIPPV. It's easier if they're just kind of hanging out. Like how do you get everybody on board to do something like mobilization? Because it's not easy. You could fall. You could pull out a tube, you could do something like
Mm.
how do you get everybody on board? And I think that that's the biggest piece is that cultural shift of change of practice. So how do you guys do that?
I think, like Ben said, we don't work on the intensive care, but I do think down there the doctors are quite pro physio as well.
Hmm.
In certainly in this hospital, I think they are very pro physio, get people up and moving. But they are, I know the ICU physios are underway. We're looking at that, the ventilated patients. But for us, again, the doctors are very pro, get them out of bed. But like we were saying before, it's made it a lot easier. I think, a few years ago, if we'd have had somebody on 100%, our old high flow would have been a bit twitchy about getting them up and
Sure.
moving. But now we've got the vapor therm, and since COVID, we are very much getting people moving quicker. And the doctor's very on board with this as well. So yeah,
How about the nursing team? Are they on board?
they are. It
Okay.
takes a little bit more time for them to get patients out. I just think they're probably not as confident as us at getting them moving when they're on lots of oxygen. So I think they probably would wait for us to make that first move and then follow on from there if everything went okay. So we sort of assess them to see how they manage first of all if they're on quite a lot of oxygen. And then
Okay.
if they manage okay, then the nurses would be happy to help them back into bed or get them out the next day.
Okay.
Yeah.
Interesting. So, the hardest part in our healthcare systems are a little different. Okay, but we still take care of the same patient. So we do things a little bit differently. Now, can you guys, like, you guys are technically governmental employees, right? You guys are employed by the National Health Service. Is that how it works? And then you get assigned to the hospital that needs you? Like, tell us a little bit about that because I think that that's an important understanding that we in America don't get. Like we don't understand it at all. We just think socialized medicine is like the worst thing ever. And no, we can't do it. But like we spend a lot of money taking care of patients and we don't get the outcomes that you guys do. So tell us a little bit about the National Health Service.
So that's a nice complicated question there.
Yes, it is.
So the NHS covers every hospital, every government-run hospital in the
Mhm.
UK, but it's sort of broken down. There's an overseeing body, but it's then broken down into what we call local trusts.
Mhm.
So for us, we work in Bradford. So we have the Bradford Trust,
Okay.
but then there's one next to us that is Mid Yorkshire, which covers Wakefield, which is one city, and then a few towns around it.
Mhm.
And each trust doesn't necessarily mean one hospital. So for us, we've got one inpatient hospital, We've got one sort of outpatient day casey sort of hospital, and then a few um, rehab. And that's
Okay.
all managed by one trust. And then when you're looking for jobs, you apply for a job in that trust.
Okay.
Um, but there's no guarantee that once you finish uni, here's a job. You've still got to wait for the vacancy and go through the whole interview HR process to get that. There's no guarantee at the end of it.
So it's like like different districts. So it's geographical. Is the trusts are geographical?
Yes, yeah.
Okay. Interesting. So how do the trusts work on their own, or do they have guidelines from like the national service that you guys within the trust then execute? So like I know the British Thoracic Society is a big deal with how you care for patients. So is it like if you have a standard of care, does it start at the top and works its way down to the trust, or do the trust itself identify how they work independently? Like, how does that all work?
So for us, the best example would be the BTS acute hypercapnic respiratory failure
Okay.
guidelines,
Hmm.
which are sort of national guidelines that we work towards. Each trust has sort of a guideline within that trust that is based, I'd say 90-95% on that, with a few local tweaks. Because again, there is geographic differences. A
Sure.
nice, lovely, scenic British town in the south of England has got very different needs to so where we work in Bradford, it's an ex-million, quite multicultural city. They're
Hmm.
very different needs. So each trust can tweak the guidelines slightly, but it's not going massively off book and saying, right, we're going to do something completely different.
Okay.
Um, it's very much sort of comes from the top down, but
Okay.
then there is a big focus on research as well in the NHS. So that sort of feeds back into it as well, is that um, we've got another governmental funded body focusing on purely on research, and that research then informs the guidelines, and it sort of works in one very, very complicated, convoluted circle.
So if you wanted to change practice at a local level, that's probably pretty challenging for you because it's top down, not bottom up. So it's if you like do you have like we call it red tape. I don't know if you guys call it that, but like we have a lot of red tape in the United States. It sounds like you have thicker red tape of trying to get something changed if you wanted to change it at a local level. Is that how that is? Is that challenging?
I think it depends on the change. So
Okay.
we are at the minute looking at using nasal high flow or high velocity therapy for reversing acute hypercapnic respiratory failure.
Hmm.
But the tricky thing is we've got to do that within the guidelines from the BTS. So we're looking at sort of mask intolerant patients or using it as the controlled oxygen therapy within the first hour of treatment as ways to sort of start that change of practice where we're not going completely off book, but we're slowly introducing it in. And then
Okay.
as soon as we have a big success story, we shout about it to the consultants, go, look at this, look what we've achieved, and then we
Okay.
can sort of get the ball rolling that way.
So there's some grassroots to change in hospitals, but to get it to change the standard of practice nationally takes a lot of effort and and a lot of research. So it's evidence-based care, right?
Yeah. So the guidelines are often not set by the NHS, but an adjacent body. So either a specific organisation like the British Thoracic Society or the NICE, the National Institute for Clinical Excellence. So they are an NHS body, but separate to the trusts,
Hmm.
and they are constantly reviewing research, reviewing guidelines, and updating it based on best practice from evidence. And then the aim is to work towards those guidelines.
That's really interesting. Really, really interesting. So changing culture is challenging. So in the United States, changing culture does happen at a local level. It's a little different because you guys have your guidelines and it's very set in stone. It's very, hey, we're going to do this 95%. We're going to follow it. In the United States, it's a little different. We know what the guidelines are, but sometimes we don't follow it, and sometimes we do. So the changing in culture does happen more at a local level and can stay at a local level without it going up. So Phoebe, have you had a success story with something that's a little outside of the guidelines? I believe you just took care of a patient that was acutely hypercapnic. Is that correct?
Yeah, so we were at work a couple of weekends ago, and there was a patient on one of the outlying wards. It wasn't the respiratory ward, it was the acute admissions ward.
Okay.
And she was found to be in type 2 respiratory failure. I've actually got it down here, the information. So yeah, the problem was there was no bed on the respiratory HDU.
Hmm.
So I think they were waiting to create a bed, but in the meantime, me and Ben sort of went down and said, well, actually, she's only mildly acidotic. Let's try just an hour of medical management. We'll put her on the vape therm, give her some salbutamol nebs and see what happens. Um, anyway, we put her on vape therm, and after 1 hour, she improved dramatically. So the CO2 went from 9 down to 7. Um, and a pH went from 7.34 to 7.43. So it was a big difference for the pH, and that was just an hour of therapy. So I did take that to one of the consultants to show him that we'd, manage that. So yeah, that was outside what we would normally do, but
Okay.
with a slight tweak. But it did work, and then she avoided an admission then to the respiratory HDU, so that saved a bed.
So,
Yeah.
so Phoebe, this happens all the time in the United States. So we don't have a respiratory ward like you guys have, but our ICUs are packed all the time. And if we could prevent somebody going to the ICU, not only does it help with bed management, but it actually reduces costs too, like considerably. I'm sure your respiratory ward is very work heavy. It's very time consuming. But like, hey, we manage this patient at a lower level. Like, what did the consultant say? So, consultant for you guys is physician for us, our attendings. So, like, what did they have to say? Like, what was the response? Like, hey, you just kind of pulled this rabbit out of a hat and it worked. So, what did they say?
I think on the actual day, the respiratory consultant who was on had actually gone home, so he didn't know. But the consultants on ward 4, they were obviously pleased that they didn't have to then move the patient, create the new HDU bed, because on the HDU, it's 2 patients to 1 nurse, so obviously that is more, costly than a patient on a normal ward bed. But when I showed it to the respiratory consultant afterwards, he was impressed that it had worked. So he was backing us to look into this a bit further.
Phoebe, how did you explain, like, did the consultant ask, like, how is this possible? Like, how, like, did you have to break down the mechanisms of action at all? And I just need to add like a quick disclaimer on this. We usually say we dance around products sometimes on the podcast, but I just want to say that like case studies, individual results may vary, but this is a great story of this one institution. So just gotta throw that one out there of your experience. But yeah, continue on. And how did you have to break down like how that was possible?
I think the consultant who I spoke to, he's quite on board with the using the nasal high flow for type 2 respiratory failure. So he had looked into it before. So I think
Mhm.
he's aware of the mechanisms of it, and he's quite interested to look at it further. But I think in the past we have had to discuss with other consultants how it works to try and get them on board. But like you said, it's difficult to make changes when things are already in place, when we do stick to set guidelines.
Totally.
Were you guys surprised by the results?
I don't think so, are we? Because I think going back a few years ago, we have used, when patients have not tolerated NIV before, we have used Vapotherm or high flow before, and we have had some successes before using it. So, but I think we were pleased, weren't we, that it did work. Yeah.
Ben, thoughts?
Yeah, I mean, it came at quite a convenient time, to be honest, because we were due to meet the consultant about this the following week. So the fact that it happened on the Sunday was perfect timing for us. but yeah, we've used the I think it was the precision flow we previously used with a couple of patients, but again, it was very we sort of knew it worked, but it was at the back of our mind because the evidence wasn't there. There was a few studies here and there, and it was a
Hmm.
sort of last throw of the dice that we used to use it for. Whereas now, as the evidence is coming out, we're a bit more confident to go to consultants to say, look, this works. If I'll show you the evidence if you want to, but we want to try this instead of NIV because they're not tolerating it. They're throwing the mask on the floor. Or we don't quite have the bed. Let's just give it a try and see what happens first.
And I think that we've seen this. So I want to shout out to Alicia Lukasic. So, and this is the reason why, is when you try to do something new, you want to build that confidence. You just said confidence a couple times in that sentence. And I think that's really important. You have to be confident as a clinician to take something new to a consultant, to a physician to say, yeah, this is going to work. Alicia on our side is like a ninja about this. She knows exactly who to find that patient to make it ideal. It sounds like you guys found that ideal patient. And I think that's what helps with culture change is if you guys are confident, does that translate to your consultants that they feel more confident when you as a respiratory physio is confident?
I think so. I think we've sort of managed to build up a good rapport and a good trusting relationship with them over the years by essentially being confident with what we're saying and it actually being effective. If we kept going to them with every new thing that we got shown by a rep or a company or whatever, and
Sure.
we said this is the best new thing, and we use it with three patients and it doesn't work, then it sort of becomes the boy who cried wolf. Every new thing, they just, all right, well, we'll let them burn themselves out with it. But we like to look at the evidence first. We like to try it. We like to almost test it on ourselves as well in a way, just sort of you can. I mean, one of the things that is stereotypical about physios is we like to try things, we like to play with every new machine, we like to have a feel of it, see what it's like. Because the argument I always make to our new staff is you can't put something on a patient unless you felt it yourself.
Interesting. Have you tried on some of your equipment, Phoebe? Have you tried it
Yeah,
yourself?
we have. Yeah, we've tried the Vapotherm.
Yeah.
We've tried.
Have you ever tried an NIPPV mask?
Yeah,
Have you ever put that on yourself? That's not
yeah,
fun,
we've
is
tried
it?
that. We've tried on the highest pressures, haven't we, to see if we're trying to get the patient to put it on the high pressures. We've always said, well, just so we know how it feels, because if they don't tolerate it, you sort of know why, because it is quite, it is a strong feeling. The cough assist as well, we've tried that.
The cough
I
assistant
think
like
that's my worst one, the cough assist.
it sucks the breath right out of you. You're like,
Yeah.
it's so awful. But oh my goodness, I love that because Anna, you might as well be a respiratory therapist. You're respiratory therapy sidebar. So we feel the same way. As respiratory therapists in the US, we want to fiddle with things. We want to see how it works. We want to understand that. But I think, Ben, what you said was really important when it comes to culture change. You knew the technology really well because you tried it on yourself. You tried it on Phoebe, just throw everything on Phoebe. She'll love it, especially the cough assist. So you do that, the clinical data, you build up that confidence. So you're willing to put yourself out there for that patient. And when it works, the consultant and the physician are confident in your skills. So it all kind of comes full circle. That's what I see. When I see a really good respiratory clinician, they know their stuff, they know their equipment like the back of their hand, and they're respected by other clinicians. It, it is that it, does that ring true for you guys as well in the UK?
Yeah, I think it's tricky to sort of compare because I know that
Hmm.
we don't know sort of what the doctors on your side do compared to ours, but I know that it's sort of if you're going in and you're being effective and they're being effective, you're obviously getting a good outcome, but it builds that trust as well in that
Hmm.
you know that if you suggest something to them and they say probably not, then you think, right, fine, I'll take that. They know the medications or whatever it is more than I do. I trust them with it. I'll leave it with them. Whereas we have worked with some doctors where you sort of think, right, I'm gonna go and have a chat with somebody else first. I remember one particular consultant who, after a long disagreement, let's say, wanted me to start a patient on a CPAP with a PEEP of, I believe it was 2.5 centimeters of water, which is
Why?
effectively pointless.
Yes. It'd be fine for a mouse, I think, maybe. But sometimes I feel that the best clinicians are the ones that can translate the the evidence, can translate the experience, can tell that story to that clinician, to that physician. And I think that really matters, that you could tell a very concise story. So we're talking about, UK versus US respiratory physio, but like really it kind of feels the same. And does it feel the same to you? Because like that just keeps coming up. And you're our voice of reason for the most part. So what are your thoughts? Like what are you observing with this?
Was there any, was that patient, was she able to either share her experience with you, Phoebe? Like, had she ever been placed on a mask? And then, like, was she frequent, we call it frequent flyers in the US? Like, the same person who's on that brink of a serious exacerbation and they uh, keep coming back. So they get used to a mask-based solution. Then they get placed on a velocity-based solution and they're like, why hasn't this been happening? And we hear it sometimes with mothers too. Like their baby is struggling with the mask and they can't conduct kangaroo care. And then all of a sudden they're like, wait a second. Like this is the preference I have is something I can hold my baby right with this high velocity therapy system. So I think that's like the last bit because you have the scientific evidence, check. Clinical judgment, check. A product that's easy to understand, check. But now that last bit is and all that feeds into the overall trust of the organization. And then it comes back down to that patient full circle when the patient says, like, hey, let me advocate for myself. This is what I want. And when you put a mask on someone, they literally cannot speak. They can't advocate. So I feel like that's the last piece of the pie in
Mhm.
this, maybe, or maybe that's different in the UK than the US.
I think definitely we do have that as well. I mean, this particular lady, she wasn't a frequent flyer. We do get a lot of them as well. So she never had an IV before, but she was struggling to tolerate even her oxygen mask. So as soon as we put her on the vapotherm, she much preferred it. She could eat and drink. She could talk to her family. I think a lot of our patients as well, the COPDs who are breathless, they don't like having things on the face. Just makes them more anxious. So with them having the nasal cannula, it's a lot nicer for them as well. And then we get a lot of patients who, if they've been on an IV for a couple of days, they do get pressure sores from the mask. They're dehydrated because they're not drinking enough. They're struggling to clear the secretions because they're on the mask. So all that helps, and you've got your humidification as well from your vapotherm. So yeah, I think definitely for patient preference, it's much better.
Yeah, and it takes clinicians like you guys to keep championing that patient preference forward. Like it stinks it takes time to do all of this. Like we talked about the guidelines and the protocols. It takes so much ti tireless effort. Like I don't- for example, the can was invented. It wasn't until 20 years later till the can opener was invented and then later adopted. We see that with toothbrush to the toothpaste, television. Uh, like it takes about 20 years for adoption, which is like crazy to think about. But like what you're doing is trailblazing for what will become, I think, standard of care. And that's like pretty crazy to think about. Like, although it's a mountain to climb.
Yeah, and I think you hit the nail on the head. It's a mountain to climb, but it starts with patient one, right? Phoebe and Ben had their patient one. They had their aha moment, like, hey, this is going to work, and I want to learn more about it so I can continue to tell that story with patient number two and then patient number three. So I think that's a really good point, Anna.
Ben, how did the meeting go when you then shared this later that week?
So I was actually on annual leave that day. So it was just Phoebe with the consultant.
But yeah, it went well. So I think we've got a meeting, haven't we, in January with Vape just to go through some more bits. We want to try run a bit of a research trial with it.
Oh,
Yeah, so we'll see how that goes.
I love
Um,
that.
Awesome.
because we are connected to a bit of a research centre here at Bradford. So
Okay.
hopefully we do have the facility to make it a bit more official, rather than having to use just their adapted guideline like we did with this lady. We can hopefully try it with some more patients that come through A&E.
It's wonderful.
Mm.
So guys, what do you want the future to look like? What do you want your jobs? What do you want in your careers looking forward? What do you hope for healthcare to look like with your patients in the future? What are you guys striving to accomplish?
I think for us, it's just at the minute we've got a dedicated respiratory high dependency unit, but
Mhm.
that's 6 beds for I cannot remember the population off Bradford on my top of my head, but essentially the answer
A
is
lot.
not enough.
Okay.
So and that then puts the extra pressure on, like the patient we're talking about, where there's not that nice streamlined flow from A&E to
Mhm.
respiratory ward to respiratory high dependency or via admissions unit. So I think ideally in the long run, we'd like to look to sort of streamline that process a bit and have it sort of everybody on the same page because we're getting the respiratory consultants on board, but we then need to work on the A&E doctors and
Mhm.
getting them to think of it as a first line treatment to put nasal high flow on in that hour and then escalate to NIV rather than just go, oh, the pH 7.34, whack them on BiPAP and send them upstairs. So just to sort of have a nice, much more structured, streamlined flow to the process.
I love it. Phoebe, what do you think? What do you want the future to look like?
Yeah, I think definitely we need more beds so we can have more patients in the same place. Um, Obviously, we use a vapotherm for patients in type 1 respiratory failure, hypoxic patients. And currently, we do have them dotted around the hospital on different wards. But as
Hmm.
I was saying, it'd be nice to sort of centralise them so they were all in one area. So we
Okay.
could keep an eye on them together rather than them being on different wards. Just have them in the same place where everybody, is familiar with the machine. So I think that's something we want to aim to do.
I like that. I
Yeah.
like that. It sounds pretty familiar to the United States, huh? Anna? Like with this isn't
Yeah.
that much different. What about you guys? What do you want in your careers? Tell us a little bit about like what you want.
Or personally, I mean,
Yeah,
this
personally.
we're recording in December, listeners, but this is going live in January of 2025. So if you have a New Year's resolution, I think that's kind of interesting too. So personally or professionally, and Matt, back at you on that question.
Back at me. What my personal?
Personal and professional, yeah. What's the
Um,
resolutions for 2025?
I want I professionally, I want more people to have aha moments. I think that when you have an aha moment, you get confident with whatever that aha moment is. That if you get confident with that aha moment and then you tell the story the right way, I think that that's what makes a great respiratory therapist to an average respiratory therapist or respiratory physio. So I want to see that more professionally, more aha moments, more people being innovative and taking chances on whatever it is as respiratory therapists. Personally, my 20th wedding anniversary is coming up, so that's what I'm looking forward to. That we're going to have some type of fun time in August. That's what I'm looking forward to in 2025. I'd like to lose a little bit of weight, I guess. So, how about you guys? Ben, what do you want 2025 to look like personally and professionally?
I think sort of professionally, we're like Phoebe said, we're sort of starting to dip our toe into the research pool.
Okay.
Potentially got a well, speaking gig lined up at the association. I always forget this name. It's a lovely long acronym. Association of Chartered Physiotherapists in Respiratory Care. So a special interest
Wow.
group.
Very nice.
So yeah, sort of started to dip the toe outside of clinical practice slightly. So yeah, I think see what that goes. And then yeah, personally, we've got quite a few music festivals lined up, so very much looking forward to them.
What type of music are you into, Ben?
So sort of indie rock, that sort of thing. So we're quite lucky in the UK in that it's a relatively small island in comparison, and there is a lot of festivals in a lot of different places. I think we've got 2 booked in currently, with potentially more to come.
We in the United States must thank the UK for your music because that's where basically all of our inspiration comes from. Anna, what are you thinking?
I was looking at tickets last week for Coldplay London in July, and like that would be unreal. All these great shows in the UK, and I was like, how can I go to the UK for work and likely around Coldplay's tour? Like I was like, how could this become possible? So I so relate to that. That's awesome. What about you, Phoebe?
I think professionally in 2025, it'll be good to look at the research because that's not something I've ever done before. Being
Nice.
involved in research projects, that'll be something new. And personally, I'm just looking forward to holidays. We've got a couple booked, couple in the UK, and then I think we're going to Ibiza for the weekend. So I love Ibiza, so
That's so
I love to
cool.
go there.
That's the coolest thing about Europe. They just
We
pick
can
up and go
go,
to a different
yeah,
go to a
yeah,
different country. We go
2 hours.
to Florida.
Yeah.
That's what
Like
we
it's like
do.
so casual that she's like, yes, we're going
Exactly.
to go jet set this way. Well, Phoebe, when you do have research published or anything, actually, to any listener, really, we do webinars in the US and we get like
Mhm.
a lot of folks, like it's a significant platform. We'd love for you to share your research on the webinars. Like you're more than welcome to. Like we're always looking for speakers on it, but also like innovative and recent research. So like that would be so awesome to have you back on in that context. And that's a lot, like sometimes like 3,000 live attendees. So it's kind of overwhelming. Like it's really cool though, but like let's get this to center stage. It's like amplify these voices further. And it
Absolutely.
relates, I think, too, in what we were saying earlier. Like you don't see a physio or RT in modern media that often. So we got to use the platforms that we have and keep amplifying, like I think the voice that is RT or physios for sure.
I love it. I love it. We always finish up our shows with some shout outs. Phoebe, any shout outs that you have professionally, personally, anybody you want to get out there and let them know how much you appreciate them?
It's our respiratory medical team for always working hard.
I love that. I love that. Ben, how about you?
Yeah, I think the same, and particularly to mine and Phoebe's mentors, who have moved on to different careers now, but Karen and Liz, who pretty much taught us everything we know and a lot more that we don't.
I love that. We all have mentors. We all have people that point us in the right direction. Anna, do you have a mentor that you want to shout out? Anybody else?
I want to do happy birthday to Jake Walter. This will be published
Jake,
like around his birthday. So huge
I love it.
HPV to him.
I love that. And I just want to say thank you to you guys. I love learning more about the UK. So my shout outs to you guys. Learning like you guys are very similar to us. We might pay for things differently, private versus public healthcare, but we're still taking care of the same patients. We're still trying to be the best clinicians we can be for our patients. So I love this episode. I'm super excited to see it published. So Ben, Phoebe, thank you so much. Anna, as always, it's a pleasure. We're going to have you two on again because I want to learn more about your research. I want to learn, Ben, I want to hear about your talk. The first time you do that, it's a little scary. So
Yeah,
I want to hear all about it. So Anna, I'm gonna let you play us out, but thank you for a wonderful episode of RT Sidebar.
thank you for having us on.
Oh, our pleasure.
Vapotherm does not practice medicine or provide medical services or advice. Any clinical recommendations provided herein are solely those of the speaker. Practitioners should refer to the full indications for use and operating instructions of any products referenced before use. Pavlich and Hayes are employees of Vapotherm. Butler is a paid consultant, and our guest is not compensated.
Real quick, although individual results may vary, Vapotherm believes this case study is an example of clinical benefit. Vapotherm's humidification technology in the hospital setting. Okay, that's it. Good job, everyone.
No, that was excellent.